session today is going to start, and we're going to talk about and the next concept when it comes to skin rejuvenation. So what I'm building on, and I'm just basically, I think I'm going to give the guidelines because last week we spoke about the first in that session, but I'm going to give the guidelines of how you're actually, going through consultations and how you're understanding what you can do to advise your patients to improve their skin. So last week we spoke about color, right? That was the main focus of last week's session. And when we're going through the skin level by level, my beautiful picture again, right? Then the color is really here on the surface. Although actually the color is made by here and, in multiple different layers, but that is what people see first. So this should be your first talking point. And I mentioned this is also the most important qualifier for how we look. If we look young, old, or whatever. Color is the most important one, scientifically speaking. The next is texture, and we have certainly incorporated a lot that has to do with texture of the skin. That we've already either addressed some of it last week, but I'm going to be spending quite some time today on texture. So that's going to be mostly our focus today. And texture is not just what we see on the skin, although we do see it on the skin, but it is created oftentimes by exactly the same. In the same dermis, where also pigmentation can sometimes be an issue, but it is because of oftentimes of collagen. Now, kind of a subcategory to texture is then not only the little bit of a pebbliness on the skin from like very badly sun-damaged skin, but also wrinkles, right? And those wrinkles are just really like super inflated textural issues. And they definitely originate in kind of the mid-dermal layers. And then we have, when we're going further down, now down here, I'm going to make it like this. This is our subcutaneous fat. So this is the dermis, this is the epidermis, and underneath we have our fat, and then we have underneath that we have muscle. So we will be able to address a number of other issues that we can talk about with our patients during any of their consultation, where we can help them along if we understand what's going on here. So many times the fat layers are either too little, oftentimes that is on the face, when we are losing some definition, when fat pads are moving down because they're no longer beautifully anchored over our bony prominences. And that's because the bone gives in and the muscle gives in also, so that allows the fat pad to move and to bunch up a little bit. So we will talk about the changes, which are the actual deep changes. I'm just going to call them deep changes in the skin, where the fat layer is reduced, and again, that's on the face. And on the rest of the body, we may have a little bit too much, and so we have the issue of how do we move this excessive fat away. The deep changes in the skin also include muscles, and this is sort of like where fillers come in for the face, or where fat reducing techniques for the body come in. And then the last, I'm sorry, I think I'm going to redo this a little bit. So I'm going to move this to number 5, and for the number 4, I'm going to go beyond wrinkles, and I'm going to talk a little bit about skin tightening. And you know that I'm not a huge fan of saying the word skin tightening, and there are very few exceptions to it because we really don't have so many skin tightening strategies. So I'm hoping what we will be able to cover are points number 2, 3, and 4. So texture superficially, wrinkles that have been created, and then altogether skin tightening, and they all pertain to the dermal layer. I want to make that a little shorter here, to the dermal layer, and this is where they are originating. So we have to work a lot on the actual dermis. Okay, so any questions about the concept of how we're approaching a consultation in general? Pretty straightforward, right? I mean, what's most obvious goes first, and the most obvious is always color, and then we're dealing with all of these others kind of down the road. The issues with texture. Can I have a white, please? The issues with the issues with textures can be kind of a combination of genetics. There are people with oilier skin. There are people with less oily skin. So there's never really one kind of type of skin that we always have. You know, when you look at children, they always look amazing. They have absolutely no oil production, so that's why they look amazing. Once you start creating these oil glands, having them go into full production, you are unfortunately going to sometimes face overproduction. You're sometimes going to face kind of graininess, maybe clogging of pores, maybe, I don't know, all sorts of different things. About 70% of the entire population will have had acne at some point of time in their life. That's pretty significant. And, you know, acne is just kind of a, you know, much more significant expression of where you have overly oil production and clogging on the surface. But so we do need to address that, and we need to be able to help those patients get to this approach. Now the easiest is obviously, okay, first let's try to exfoliate the skin, because what happens many times when there is this overly oil production, here you have your monstrous oil gland, okay? I'm just saying that's the oil gland when it's really in full production. Here's your hair that's coming out. And what happens oftentimes is the oil gland kind of produces all this oil here, tries to make the hair glide out very, very nicely, but in reality you have some sort of like a plug on top, and that is when we really create acne. So the oil is trying to flow out, it cannot. So what happens? It's kind of stagnant here. The hair is still kind of coming out of the pore, but it becomes stagnant, and now you're creating a really enlarged pore underneath, and your hair follicle looks like this now. And it's a whole big thing of oil and hair follicle together. And then the swelling that is created through this attracts cells that are moving in. They say something is not right here. Why are you so swollen? We don't like that. And they're trying to attack that area, and that creates the inflammation and acne. Right? So now if we undo this portion by exfoliation, and this is a genetically regulated portion whether or not we want to create this over kind of bearing on the follicle. If we want to open this up, the best thing to do first of all is exfoliating. In how many ways can we exfoliate the skin? Jenny?
Well, mechanical means.
Yeah.
Chemical.
Good. And what do you have for mechanical means?
Microdermabrasion and dermaplaning.
Okay, good. Center City. Kristen, what else do you have for mechanical means to open up?
A chemical peel.
Okay, that is not a mechanical way. That's a chemical way.
Yeah.
Do you think there's anything else that might help in the mechanical?
Like a scrub.
Okay, so this is what patients often do at home, right? Now, if they're scrubbing their skin or brushing their skin every day, like they're buying these Clarisonic devices and so on and so forth, and they come in, they say, oh, you know, how safe is that for me? Can I really use that? Now you look at their skin, you see acne, you're going to say use that once a week, period. Don't use that every day. It may feel great on your skin, but what you're really doing is you're creating more friction, more thickening of the skin, more acne. And it's a paradoxical effect, so very, very important to look at whether or not somebody is actually scrubbing their skin, right? So you want to make sure that proper exfoliation can be done, and if they want to go to the measure of scrubbing, let's say at home with apricot scrubs or with any of those things, then they get really, really nice texture. But if it's not working for them, and it's not reducing the acne because they're creating more acne through this process. And so it's really very important that we understand when we are doing anything mechanical to the skin that we're not overdoing it. Okay, so microdermabrasion is something that we would do probably no sooner than every 2 weeks, and I think I only do that on melasma prone skin, otherwise it's probably better every 4 weeks. Although I think there are, you know, some very, very, very grainy people, they could probably use that every week and until you have some sort of a playing ground there. But again, you don't want to overdo it. And dermaplaning, I don't think that we're doing this any more than how many weeks? 6 weeks usually, because most people don't use that for the mechanical reduction of their clogged pores, but they use that for hair reduction, which, you know, personally I'm gonna have to say I don't know how I feel about this. It's definitely a great way of removing this peach fuzz from the skin. And if this is what makes people happy, then that's okay. But dermaplaning has, in my opinion, just as Channing said, another proportion, which is the actual exfoliation of the skin, for which I like it much better. Right? So I think, but then again, if you treat somebody for hair loss and they're making really long peach fuzz because I put them on Rogaine 5%, by all means they should be doing the dermaplaning or anything else that removes that extra hair, right? And the scrubs you're just going to pay attention to, just so that you know what your patients are doing at home. All right. So now they're doing already they have some very, very beautiful skin, and they have, let's say, scrubbed once a week, and you feel like the texture is nice and smooth. Now, what else can you really do for them at that point of time? In terms of texture, probably relatively little. So you advise them to kind of just stay with that particular type of regimen oftentimes. If whatever works for them seems to be a good regimen. We have sometimes these acne flares who have, closed and open comedos galore. Like, there's no tomorrow. And you don't even know that any acne medication can really touch that. Although all the retinoids are supposed to undo this plug up here. The glycolic acid is supposed to unplug it. But ultimately, only microdermabrasion, done maybe 3 times a year, 2 times a year, is getting them to that state where they can really actually enjoy some sort of acne-free period. Okay? All right, let's move on. Any questions about mechanical exfoliation? Okay, we're going to move on to chemical exfoliation. What methods do we have for chemical exfoliation? Okay, Rebecca.
Glycolic peels.
Yes.
Or like the glycolic wash.
Yes.
Okay.
It's very minimal. So when you do
Okay.
a glycolic wash, it has definitely nothing that compares to glycolic acid, either leave-on or by peel. But it's a nice way of at least introducing something that has a brief contact, is not harsh, and drives some of that exfoliation. But it doesn't work like an apricot scrub would work, right? It's not like immediately everything is sort of like smoother and more even. With a glycolic acid wash, you're usually looking at repetitive utilization. So if somebody's really using this for long periods of time, you can get some really nice results with just simple glycolic acid wash. But if you're wanting to get to some more dramatic improvement right from the get-go, and not just as a supportive measurement, then a peel is more appropriate in that particular regard. Okay, so glycolic acid peel, great option. Next. Salicylic acid. Now, salicylic acid is something that we use in a number of different conditions. One, most important, is with acne, because it has a nice way of opening up that kind of overgrowing piece here. And it just really does that almost with a little bit of a pop, which is really, really nice. You get excellent results with that in somebody who can tolerate it. Salicylic acid is not always easily tolerated. And we're using a relatively high concentration of salicylic acid. There are some people who only use 20%, ours is 30%. I think for acne-prone skin it does work better. We're using salicylic acid in a much lower concentration when we're thinking about doing just peels for improvement. There are a number of peels out there called beta peel, for example, and I believe the beta peel is about between 15 to 20%. We don't use it here, but it's a nice peel to have if somebody just is looking for that a little bit exfoliation. It's called, in contrast to glycolic acid, which is also referred to as alpha hydroxy, salicylic acid is referred to as beta hydroxy, and hence the name beta peel. Okay? And in even smaller concentrations, it is used for the treatment of rosacea. How do we use it in the treatment of rosacea? Usually not by itself, but in conjunction. So when we have our Quailage peel, I think we just lost them. If we use, are you guys there? I know it's a phone call.
Yeah, we can see you though. We can hear you.
All right, good. We're going to move back to the screen in a second. All right, so salicylic acid 10% is in the Quailage peel, and the Quailage peel has also azelaic acid and mandelic acid. Mandelic acid is a type of alpha hydroxy acid that is used predominantly to try to calm the skin. And azelaic acid, is one of your pigment correcting substances, and it also helps to reduce inflammation, and that's the reason that we use it in rosacea. Now, in rosacea, the idea is not simply the exfoliation that we're actually discussing right now, but the salicylic acid component in it helps the exfoliation and helps the other substances, particularly azelaic acid and mandelic acid, to get to your inflammatory rosacea. And that's the reason that we use these substances in the treatment of inflammatory rosacea. So Quelash peel in inflammatory rosacea, you're not ever trying to reduce the redness. Quelash peel can't do that. The salicylic acid is low enough that it will not induce additional redness, which you typically get when you're treating an acne flare, right? So with a small concentration, you usually don't get that kind of aggressive erythema after the peel, but it's simply there to help open up and allow the other substances to move in. Okay? So for other chemical exfoliation, other than alpha hydroxy and beta hydroxy, what else do we have?
Gamma.
Who?
Did you say Dana?
Gamma.
Oh.
Gamma? Okay, so we don't have gamma hydroxy acid, but maybe we should invent that. It was a good point. So somebody needs to come with that. Okay. What else do we have?
TCA.
Yes, okay. Bao was too silent in her in her wording, but absolutely appropriate. TCA. And we spoke a lot recently about TCA. There's the 17% gloss peel, and I'm going to spend a couple of minutes on the gloss peel in just a second. There is the 30 or 35% that we use if somebody has kind of sun-damaged skin and kind of wants to have an all-around improvement. Nothing of really great improvement, but something that they do one time that lasts them a year. And that 30 to 35% TCA is a great...
But that's by you.
Yes, sorry.
No, that's fine. I don't want it.
And then we have another way of using TCA, and you know that also, and that is the cross technique. And this is a technique in which we are actually allowing some of this TCA to flow into this very enlarged pore, inflame the wall, and allow the wall now to kind of become glued together after the inflammation has taken place. So it kind of goes all the way down here, inflames, and it glues it all up, and then you have reduced your pore. Either very, very deep pores that occur in the mid-cheek area, those skinny ice pick scars for which it works really, really well. But anything that's broad, you're only chewing up without closing up, and so you're only creating more damage. Okay, so the cross technique. This is actually an abbreviation for chemical. There are multiple ways of saying it, but kind of reorganization of something scars.
What do you think, Val?
I forget always the whole name for the cross, but I have it written down somewhere. Okay, but in any event,
I clearly don't.
I'll come back to that. The 17% gloss peel, again, we hardly use it. I'm not sure why. It gives really nice results. In my opinion, it's a great peel that you can do every 6 months. You don't have to do in a series of 3 or 4 or 5, like where you have the added benefit in glycolic acid, where you can go up steadily if you do them every 4 weeks.
I don't even know how much the gloss peels are.
Okay, all right, there we go. We'll talk about that right now.
Okay.
Ready? Gloss peel.
Yeah.
Okay, I'm gonna move some of my drawing away. Not everything, but some of it. Okay, so the way that I had originally thought about the gloss peel and the way that we brought it in is to address 2 issues. One is texture and one is color. The gloss peel has the ability for us to add, and this is how actually also they were priced, to add, if we want to correct texture, we're basically giving our patients, in addition to the peel that we're performing with this small kit that it comes in, we're giving them a gloss. Gloss is brilliance in a bottle.
Which I love brilliance in a bottle. That's my favorite thing, and it's even in there.
It's not in there. You add it to them, and basically you give that's kind of a bonus that the patient gets. brilliance in a bottle. I think, Channing, I feel like I'm making you a believer.
Well, that's
Take me 4 weeks, but
you know
I
who
will
got
make
me on
it.
Brilliance in a Bottle is Jenny. I mean, I have been buying Brilliance in a Bottle for whatever 4 or 5 years.
There
I
we
love
go.
it.
So basically, you do the gloss peel according to the package. It comes with a small kit. It's really just for post-treatment recovery. It's not really a bombastic kit. It's not like in the Melanage kit where you have sunscreen for a month and everything else. So please do open a gloss package, check it out, see what's inside so you understand what you're really giving the patient. But it's really this post-operative not get too red kit. Now, I've had a gloss peel, I got no red at all or hardly red. I mean, nothing red ever really bothers me. And so it was fine. I also left mine on rather than taking it off after 2 hours, but go according to the manufacturer's recommendation. And, you're supposed to have your patient wash their face after 2 hours when you do the gloss peel. Now, the other thing that we do with the gloss peel, since we are already kind of opening up, exfoliating very significantly, we're adding we just lost the image again. We're adding for the color in those people in whom color is an issue. We're adding the Melanage brightening cream. Again, this is something that we add to it. The gloss peel itself is not so expensive for us to purchase that the total of the current cost of the kit is $330. Will accompany the Brilliance in a Bottle. Basically, we're giving to patients at the cost that we purchase it for, or the Melanage brightening cream. But the kits are not meant to be sold at $330 without either one of those components. Does that make sense?
It's one or the other.
It's one or the other, and you assess. I mean, if the patient has no color issue, don't come at all with the idea of trying to give the Melanage brightening cream only because there's tretinoin inside. Mm-hmm. But on the other hand, if you feel that, let's say, the person would do better with a retinoid afterwards, then just be my guest and you throw in. I mean, you feel like the Melanage brightening is not the right and the Brilliance in the Bottle is not the correct thing because who knows? I don't know what could be that you think it's not the right fit, and you felt you would rather give them the Vard Rejuvenate instead. They're all about the same price point, so to speak, okay? So you could also do that. It just always has to be locked so I understand what kind of prescriptions you issue. Now this is not a prescription substance, but the Melanage brightening cream and the Vard Tretinoin cream, they are prescription substances, and I just really need to understand what you're doing and what your reasoning was for those kind of things. And I obviously think you're very capable of reasoning why you're doing something. With the Melanage brightening cream, as you know, you have a lot of flexibility in compounding. And I'm going to have to say this now, particularly to the newer ones who are not quite so familiar yet with the compounding of the Melanage brightening cream. Kristen, have you used any of the young products before?
We had the rep come in and she kind of did a demo of it all. We did peels on each other, but that was all.
Okay, so you haven't actually compounded. So it gives us a lot of flexibility, but I don't want to have the Melanage brightening cream kind of misconstrued as a number game. It is a very, very serious substance that we're mixing there. It can contain retinoid if you want to. You can go as high as possible if you want to, but you have to understand, if you're going high in a prescription substance, you need to be equipped to be able to walk your patient through what they are going to get as side effects. And if you don't want to be doing that, then you shouldn't be mixing any Melanage brightening cream at all. So you need to have some level of understanding of what you're putting into these substances. For example, let's talk a little bit about the retinoid component. So you can, if somebody says, oh, I've never done really well with any retinoids, you just leave the retinoid out. That's your derogative. You can decide on that. If you say, yeah, that skin is so sensitive, I'd rather only use 0.025%, mix it this way. If you have somebody with super oily skin who swears that they are really, 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 really tolerating the 0.1% concentration well, you can try to mix it. You're going to get a little into the calamity of having too much liquid for too little cream. I think it's not perfectly designed for it, but you can try to stretch it a little bit. Maybe you get to something that's closer to 0.75%, but 0.075%. But it's important that you have some considerations in mind for that, and that you do instruct your patients to not be pregnant when they're getting a retinoid, and to use caution when they're getting anything waxing or anything that might be abrasive on the skin, or if they're coming in for facials, that they're definitely stopping their retinoid the night before. I think it might be better even if we put stickers on that kind of say contains retinoid, if we put it in, and with the warning of pregnancy and waxing kind of printed on it. So I'm thinking that I think we need to put these stickers on just so that there's no confusion. And then in terms of the Arbutease that you put in, I want to say it again, Arbutease does not mean that there's no hydroquinone. It's just converted into hydroquinone all the way deep down. It doesn't inhibit your melanocytes high up, which is nice because it doesn't give you white spots. Really, really, really great. So you allow the Arbutease to move into the dermis. In the dermis it gets converted to hydroquinone, and there it actually does its job, and it gives you very, very nice and even color rather than the blotchy color of putting hydroquinone on. And so you can be a bit forgiving in the concentrations of the Arbutease. The most common concentration is still going to be the 4% of the Arbutease, and that will mimic what hydroquinone can do for melasma when it's dispensed as a 4%. So you always have some sort of a guideline because you've worked with hydroquinone for years, and you have a little bit of a sense. The 2% over-the-counter strength you can put everywhere because it doesn't really bleach. The 4% is preferably only used as a spot treatment. And we have a 6% hydroquinone in the office. Our Rad hydroquinone, guys need to know that. It's 6%, very, very powerful. You only use that as a spot treatment. You don't actually ever use that kind of, oh, put over your entire face, it will nicely fade you. No, it will look really, really patchy, really awful. And that is not designed as a spot treatment. It has kojic acid 4% also in order to give you that extra bam. So if you have an area that has hyperpigmented, let's say even a patch anywhere on the face or on the neck or wherever, you can use it over the entire patch as long as you tell your patients not to spread it over, because you really don't want that white margin all around. Okay, so I think we lost them again, the picture at least. So it's very important that you kind of think about your Arbutease, although you don't create that immediate damage that causes a faded spot on the skin. But you also want to understand what you can do with it. We sometimes have these people with, like, melasma that there's no tomorrow, or awful post-inflammatory hyperpigmentation on the face. And sometimes we feel that we really need to go to 8%. But these are real exceptions. And these are oftentimes people that we discuss before we even treat them, or they may have even failed a first Melanage peel that was done with a 6% concentration, and they may not have gotten the striking 80% reduction of the melasma. And then we can maybe go to something that's a little bit higher. But that's not something that you decide on the spot and you say, oh, I'm just going to use 8% today. That looks dark enough. It's really, really something that we want to be very careful with. In a physician office, we can do that. That doesn't mean that everybody who gets Melanage brightening cream gets 6%. And you have to also understand, if you discontinue these substances that work deep down in the dermis, all of a sudden, so in other words, you're giving a patient the 6% and you say nothing about how they actually need to trail down from this, and you just say, oh, use this for 2 months and you'll be fine. What is going to happen? That these enzymes that were nicely suppressed down here in the dermis, the tyrosinase, that this enzyme is going to say, I'm going to fire up right now. And they're coming back with a vengeance. So not with a vengeance getting more, but all of a sudden you kind of forgot about the principle of how you wanted to actually move this enzyme into a relatively little state. And so you have to think about how you're titrating down. And it's very, very important concept not to forget. So it's not enough to say, all right, let's knock that pigment out, but you want to have a way of how you're reducing it efficiently over long term. And kind of the idea that I have in my head is, if I start somebody on something that contains 6%, I am, for the whole face, 6% Arbutease, I am going to go down after 2 months when they're through their jar and have them use 4%. And then after that, I'm going to make a decision whether I want them to use 3% or 2%. And I'm thinking about approximately 6 months time frame over which I'm achieving that. Now, there are some patients in whom I have done 6% Arbutease first, and I see them back, let's say, 2 months later, and I decide, that was amazing reduction. Maybe I can work this out without even having to use any Arbutease at this point of time and simply use other feeding agents, but I don't let them go without anything. So sometimes I convert them to the melasma emollient cream after the 6%, but that's really rare. So for me, it's more 6%, 4%, and then melasma emollient cream. Sometimes I do go, however, to the 3% or 2% Arbutease. That depends a little bit. My goal is also that after about 6 months, I do not have them continuously use Arbutease anymore. With hydroquinone, and for the same reason we should think about Arbutease the same way, we have the ability to actually do something deep down in the dermis that is called exogenous ochronosis. And this is a paradoxical hyperpigmentation that happens in the dermis, and it happens after years of hydroquinone use, like uninterrupted hydroquinone use, and that is something that we don't want to get to because that's not treatable. Maybe with a picosecond laser, I don't know, maybe not treatable at all. I don't really know that we have anything great to break that up when that occurs. Okay? Any questions about gloss, Pierre?
This isn't necessarily about gloss, but it's about Arbutease. I had a patient whose dermatologist had her on 8% Arbutease, 6 weeks on, 6 weeks off, and just continually doing that. And don't we typically, besides the fact I've never given anybody 8% to begin with, but we like more of the 6 month together.
My issue is with the tyrosinase. That is the enzyme that we're actually inhibiting when we're working with hydroquinone and Arbutease, right? And so if you are turning it off or suppressing this enzyme and all of a sudden it stimulates, again, it can flare up. So I am not familiar with this particular regimen, nor can I find a particular scientific reason why it would be done this way.
Okay.
I'm not sure what it's based on. There might be a rationale that I'm entirely not aware of and I can't think of. But I'm going to say, I hope the person did think about that. Right? And I hope there was a rationale that is behind that, rather than just simply trying to give their patients something that kind of gets that knockout effect, and then they have to come back for more and come back for more and come back for more. Right? So I'm not sure. Again, without the rationale, I just cannot think of a reason why that would be appropriate treatment. Right? And when you encounter these scenarios, you have to ask yourself, was the patient properly educated? Was this really done with a rationale? Or is there somebody at play who is simply a crook and or doesn't think about what they're doing and or has financial motivation? Many people charge by the amount of Arbutease that they put into the Melanage brightening cream. They don't use, Bao's familiar with that, they don't use the kind of, so I don't want you guys to be tainted by how much the Melanage brightening cream costs. You need to make the decision based on need and not on how much more there's going to be a charge in that. Okay, so this is, I just want to take that element out of the whole process, because it's the same for the acne scar treatment. It should be always even so that nobody is kind of more encouraged to do this versus that. And so same with this, same with the treatment of the hyperpigmentation. There could be financial reasons that were behind that, but I don't know that. And also, this brings a very, very important point. Now here you have to try to explain your concept. And you have to do that in a way that you don't put this physician into a bad light. And how do you do that? Ultimately, this person may think, well, was I maybe not properly consulted? When you come with your rationale and you actually explain these kind of concepts, and you have to think about what you're doing. So it takes a lot of trying to say, I think this was a good idea. You're here today. Why don't we try it differently? Perhaps you might have more success, more sustained success, if we were to go a different route. So go away from saying, I'm not familiar with that. You can maybe mention, okay, I'm not particularly familiar with this concept, but you're here today, let's try to see if we can do it differently. Work more on the positive, the going forward component than what they might have done. And this comes up in many scenarios, and you may ask yourself, why have they done it this way? It sounds so counterproductive. And there are many patients who come to us where we feel, from what we understand about the matter, it appears not right, but we don't say it. We don't say to the patient, you were improperly treated, right? I think that is where you, kind of that finesse comes in also a little bit, right? Where you hear the patient out, you're going to say, interesting. Okay, let's see what we can do going forward, rather than dreading on the past. Okay, so any other issues about Arbutex, gloss peel? Rebecca, Kristen?
No.
No? Yes?
Texture, color.
Yeah.
Texture, color. I'm just thinking sorry, of who I would do,
Who would be a good candidate? Okay,
Yeah.
so anybody would be a good candidate for
Okay.
this gloss peel. Anybody who says, I need a pick-me-up. I feel like I'm looking dull, right? I haven't really done anything for myself in a long time. And it's not your person who is has never done any skincare and is full of milia and is full of clogged pores, but somebody who kind of engages in some skincare, they understand sun protection, and they are simply in need of something. Again, they want to do it maybe just one time. They don't want to do a series of glycolic acid peels for which they have to come see you every 4 weeks, and you do 4 peels until you get to 70%, except never in rosacea. What's the mark of the cutoff in rosacea? 50%. Just want to make sure that Kristen hears that all. Also. Okay, so, but in any event, where you feel like, okay, take myself for example. I'm saying I need a pick-me-up. I have a reunion to go to, and I need to look great. Make me look radiant. You're going to say, I have the right thing for you. Let's use the gloss peel. And if you're not using a retinoid already, we're going to have you use the Brilliance in the bottle afterwards until you're done. Or if you really like it and you like it better than your retinoid, you can even continue that. Okay, so you kind of filter that in. And you tell this person you're going to see maybe, some people can see maybe about 3 or 4 days of peeling. If the peeling is too intense, go into the steam shower and just kind of rub it off a little bit, but be gentle about that. There are some people who don't get that intense peeling. Those people who use retinoids regularly before probably do not get that. But those who don't use retinoids on a regular basis, they may very well get some peeling. They usually don't get aggressive redness on the face. Usually it's just a few hours and not the next day anymore. But the peeling is something that you want to communicate.
Is TCA the only thing that's in that gloss peel?
Technically, yes. Well, there are some supporting substances,
Right,
but
okay.
other than that, no. And if you have, if you have somebody with color issues, who can we pick out? Okay, so here is Dr. A. I'm going to mention her. So she has some fine freckles, now not so much anymore because she is a huge believer in the PicoSure focus lens. And, but she had some fine freckles on her face. And she says, I have that reunion also. I really need to look amazing, right? And then you're going to say, I have the right thing for you, right? She doesn't have like really deep wrinkles. She does have anything where you feel like the skin is not, doing something. She uses glycolic acid all the time, very regularly. She's really good about all of these things, but let's work a little bit on those freckles. Maybe we can tame them for a little while. And you're going to have to say, this is not an all fix for freckles. This is not like you're going to be looking immediately porcelain colored, right? But your freckles are going to diminish a little bit. And so you're going to serve her with the gloss peel. You're going to say you're going to flake. And she said, don't worry, I used my retinoid regularly, right? I'm not going to flake. But, okay, she's not going to flake. And you're going to ask her to use a Melanosh brightening cream. You're not going to try to kind of go overboard and try to do something that you would want to do in melasma. It's going to be sufficient to get to about a 4% Arbutex in this. She says, I have my retinoid at home. I normally use 0.05%. And then you're going to say, okay, I mix the 0.05% in the Melanosh brightening cream, and you just don't use your retinoid at home until you're through the container. And you're going to be looking really, really nice by the time that your reunion comes around in about 6 weeks. Okay, so these are the scenarios. Not somebody who really has issues where you feel like, oh my God, I really need a little bit of armamentarium to work on this person. It's just not going to come by itself. It's sort of like, an average person who engages in skincare. Make sense?
So we're doing
Yes.
this up to Fitzpatrick 3,
So-
4.
Right, so Bao raises another point. The gloss peel is a peel that we will not use in somebody darker than a Fitzpatrick 4. Right, so Fitzpatrick 5 and 6 is definitely out. And I have really not seen hyperpigmentation in Fitzpatrick 4. Different with 30 to 35%. You're not going to be ever going to somebody who's a Fitzpatrick 4. Leave that to me. And definitely not the cross technique. Don't even advise that I'm doing anything that's magic. Leave that up to me also. Okay, so there are certain no-nos for certain concentrations. But with the Fitzpatrick 4, so I'm going to have to say maybe not African American Fitzpatrick 4. I'm not sure. I think I'd be a bit more careful there. But like a Mediterranean, lighter, Northern Asian, I think these are all the candidates that are going to be doing really good.
What about this one?
Yeah, I think Bao is right on the borderline for me. I'm going to
You're
have to
always
say,
that person.
I think I would probably attempt it, and I don't think that you're going to be looking at any side effects from it. I would definitely not make your skin white with it, which is my concern when we're looking at that thicker melanin that we see from the African subcontinent. Okay?
So if I can't use the gloss peel and say
No, I think you can.
I mean, no, not for like patients that are like 5, 6.
Yeah.
Can I do a mini melanage peel?
Totally.
That's what I would use.
Yes, and that is
Yeah,
what
like
you
a
would
sense of
use
makeup.
in your number 5 and 6 when they have some pigment. They just want to look nice and bright, and you have a little bit of retinoid in there in order to actually help get also a nicer texture onto their skin. And so that's exactly that scenario that fits in. Okay? So in a 5 or 6, you would be resorting to your mini melanage peel.
Because it's that TCA that you're not wanting.
Right, exactly. I do not want that TCA in there. In the mini melanage peel, we have a little bit of kojic acid inside, also for color brightening, little orbitase inside, phytic acid. So all of those are kind of just giving you that nice kind of refreshed look, and tiny bit of retinoid to give you that nice texture of the skin. So what better can there be? Now, if you're trying to take melasma out with the mini melanage peel, I'm not sure that I can really do that, but there are some people who don't want the massive downtime of the melanage peel, and they just really feel, okay, we'll do a few mini melanage peels, some microdermabrasion in between, maybe some pico laser in between. Maybe they just cannot afford all of that downtime. Okay. Any other questions about textural improvement on the surface?
Can we talk about the advanced brightening cream for body?
Go ahead, shoot your questions.
So I've been lowering, depending on like I guess the areas, but I lowered the tretinoid but increased the aromatase for the body. Is that how you want it, or should we keep
Okay.
it 0.05?
So, tretinoin is very, very poorly tolerated anywhere but on the face. And Channing will tell us exactly why.
Because we don't have all the little oil glands everywhere else.
Exactly. All right. We're missing oil glands in that abundance that we have otherwise on the face. So we are really doing poorly with retinoids anywhere else on the body. And it usually translates not so much in retinoid dermatitis, which is what you get if you just simply use too much of it, which is the redness that occurs within a day or two of using it, but it usually translates into itching. And the patient sits like that and like that and like that and doesn't understand why they're itching. And it's the retinoid effect. So the retinoid dermatitis manifests a little bit differently on the rest of the body than on the face. Not usually so much redness, although you could certainly get that on the neck, but the itching is what gets you. And that makes it really uncomfortable. And people don't realize at first it's their retinoid that makes them itchy. But it is something that you have to talk about at first. You have to understand if a person can commit to it, or it might be just too bothersome to go through that. By lowering the dose to something very, very minimal, for example, 0.01%, I think that would be okay. You have still a little bit of some turnover that's happening, and it is a very, very weak concentration. I believe it's probably tolerable on the neck, chest, back. Trying to go up in the arbutase too much to try to overcome it is not necessary. You can instead think about a little bit differently. So you have your Melanosh brightening cream that has a little glycolic acid inside. That's already helping you to break open a little bit the barrier to do a little exfoliation. So it's not like you must absolutely have that that way of trying to perforate and get the arbutase there. By creating too much arbutase, or by increasing the arbutase concentration, let's say, so I don't really make a difference between face or anywhere else in how much arbutase I'm mixing in. I usually, if I were to use a 4 on the face and I have a similar spot on the body, I would do the same on the body, because also my thought is, if I'm depressing that tyrosinase, I have to somehow get out of that. I need to titrate them down over time, over a long period of time, and now I have to ask myself, how do I go about this area, let's say, of post-inflammatory hyperpigmentation? What were you thinking about? Sun damage on the chest, or?
Just discoloration, a lot of PIH,
PIH,
scars,
right, so,
and stuff like
right.
that.
So for post-inflammatory hyperpigmentation, I'm thinking, okay, maybe I have to be really very careful. From 8% to go to 2%, that's going to take me a really long period of time. From 4% to go to 2%, it's not going to take me very much time at all. And then if I feel like I need to use an additional method to try to overcome the let's say the restriction on the retinoid, you can also think about combining it with some microdermabrasion treatments in order to mechanically loosen up that pigment that the tyrosinase is now no longer encouraging. And so I think there's a number of ways of how I think about that, but not by going up on the arbutase, but yes, definitely going down on the retinoid. Or leaving it out. I mean, I oftentimes leave it out unless I feel that there is absolute merit to needing it in there. And again, 0.01% would be my preferred concentration if I really want to have it in there. The chest has a bit more oil glands, particularly the central chest, than, for example, the neck. And so if you have somebody with lots of sun damage who wants to do it on the route of using Melanosh brightening cream, just to get a little bit more even look, not to remove the sunspots, but just a more even look, then I would go with a very low concentration of the retinoid.
But why are they doing that over not just doing a Pico?
Yeah, maybe they want not the expense. Maybe they say, I love my freckles, I just don't want them to be so pronounced.
Okay.
I don't know, there can be reasons. It is not something that I would, if I'm doing a consultation, this is not something that jumps to my mind. It jumps only to my mind when the patient is telling me that is too aggressive. And I also love my freckles too much. I really don't want to lose them.
Okay.
Right? I have a patient who says, don't ever do anything to my freckles. Whatever you do, I want to keep these freckles. I've had them all my life. Just don't do anything to destroy them. It doesn't matter that I tell her, you could be looking so much younger. I should not be saying that, right? But so I have to be sensitive to that. Okay. And then you want to be sure that you're not putting 8% in, because yes.
God forbid we get rid of
that
those.
high.
I've never
used that.
Okay.
6%.
I'm just saying. I mean, I use 8% very rarely, but here and there we use it. Any other questions about our texture? No? Now my question is, did we address all of the texture, all of the superficial texture? Do we have other technologies other than mechanical or chemical to attack texture?
How do you like those Clarisonic brush that people are always using?
Right, so we spoke about that before you came
sorry.
in, so it goes under the category scrub, where if somebody has acne-prone skin, we want to make sure that they're using something like that, either that or the apricot scrub or what have you, just about once a week, because it creates more acne. If they have normal skin and really no acne breakouts, they can get away with using it more frequently, and I don't mind that they use exfoliation if it works for them. If something doesn't work for them, they're creating more acne, more oil production, and they feel like, oh, my skin is just not the same, then you have to really speak to them about how they're using their scrub. And it's always important to ask.
Okay.
Okay? All right.
Sounds good.
Moving on to the next way of how to improve texture. How's that? I'm going to call this A, B,
Yeah. Are we like jumping to like your
C. Now,
CO2 pixel type
so
thing?
pixel, yes.
I have to say
Good.
that just for you.
Pixel for Bao. Pixel for everybody else
That's
in
right.
Center City soon also, okay? All right, what else? Light CO2 laser, super light, just to get the surface all nicely smooshed out. And what else?
1540.
1540. What number?
Well, first we're going to do 2
No,
passes of
first of all, now you're thinking, if it's
XF.
only little graininess, and you're
Right.
not trying to get to those wrinkles,
Okay,
and you're not trying to correct here.
right.
You're thinking only superficial.
Only superficial. F for official.
Yes, good. Okay, then you can bring in your 1540 XF.
Okay.
Okay, and if you say, oh my God, that person really grainy. Oh, they need improvement. Let me do 2-3 passes of the XF, and they really don't have really much of wrinkles underneath. Then that is the right thing to do for that person. Okay, but not. There are also wrinkles that this person wants to correct, and it doesn't all look that hot anymore on the skin here. Then you need to include the XD. You just can't do it without it. The person will see not anything. But if they have that graininess and nothing really looks right on the surface, then this is your power tool. You're going to say, you have how many weeks until the wedding of your son? 4 weeks? Too little. Okay, won't do anything really. Maybe we'll have to do a pixel. Bao's going to say, 4 weeks? Yeah, I have the magic potion for you. She's been selling Elastin like there's no tomorrow. And that magic potion will come in and she does a pixel and that person looks great at the wedding of the son 4 to 5 weeks down the road. Would you agree? Yes. Okay. The same, you can get a little less downtime with the 1540. You kind of have that knockout also. They can see me for the 30% or 35% TCA peel. They get that nice result as well. I'm probably going to serve them with the same elastin cream in order to speed up the healing. Superficial CO2 laser peel can also be done. They all fall in this category. Now, if the person is expecting a CO2 laser resurfacing and going to the wedding of their son in about 4 weeks, I'm going to have to say, no, I'm not doing that. That's a whole different animal. And when we're doing CO2 laser resurfacing, and I don't mean this particular here, which I call CO2 laser peel. This is really a superficial peel that I can do anywhere. On the chest, on the neck, on the face. And it's just basically, all those kind of create the same thing. More downtime with Pixel and CO2, less downtime with the 1540 XF. Okay? Texture.
Sorry, it's off subject. CO2 for acne scars, what skin type do you go up to?
You can use on all skin types. Right? So with the CO2 laser, I have the ability to dial it in deep and or to use superficial components. So I can just skip the superficial components, so I'm not hurting the epidermis, and I'll dial it deep so it actually reaches into the acne scars.
Okay.
And so I'm going to have to say there's no restriction since the Deep FX portion came out in 2007.
Okay.
But what I feel works better at this point of time is still the Infini. Better than the CO2, less damage, particularly. We do get hyperpigmentation on the skin type 4. We usually use on all of the skin, darker skins, we use a little bit of Kenalog on top of the skin that kind of just seeps in right after the procedure, just so that we can prevent the hyperpigmentation. And it works relatively reliably. When we forget it, that is sort of like when the patient comes back and has all of the darker marks that we see and say, oh my God, we should have done it. But in general, it's a pretty good technique to use just a little bit of topical steroid. It usually takes 0.3 cc's, which is not very much at all, of the 40 milligram per ml solution that we have, and I usually rub in one drop on this cheek, another drop on this cheek, and the last drop goes over the forehead, nose, wherever I feel like I need that. And I do that routinely after CO2 laser in those darker skin types also.
Is there, I know because we were talking about it yesterday, why is it that we can't just Kenalog everybody to death? For 1, 2, and 3.
Okay, so it's a steroid, and it's a very potent one, the 40 milligram per ml, and we might induce rosacea and
Okay.
perioral dermatitis, and I think the risk is very little if we do it one time. But I have some aversion.
It's just not necessary.
It's just not necessary. So you're thinking to reduce the inflammation and even like any average person?
Well, not me, but like a skin type 3 where the way they look like, she says she's, German, but she just really looks like she probably has a little bit, I don't know. I get nervous because this is still new to me. So I don't want you coming back with dots on your face.
All right. I think it brings up a good point, and I am open to discussion on that. So if you feel that there's a particular skin type, let's say you ask the history and they say, no, only German. I have nobody else in my family. And you feel still, I'm not really so sure how I'm trusting this kind of skin, you can put a little steroid on. I don't mind that at all. And there are many scenarios where we prescribe steroids, very potent ones.
One of your 2 o'clocks are here.
Oh, thank you.
After the procedure, photodynamic therapy, very, very common, and we usually treat people with skin cancers or precancers of a very fair skin type, and they are just going into this massive inflammation, and so we do use even topical steroids there for a whole week, and I'm not thinking, oh, am I going to cause rosacea in them? I'm going to have to deal with the rosacea afterwards. I also need to get them out of that very, very severe inflammatory reaction. We do use it after some of the Infini treatments. I think maybe Dana treated somebody the other day, and she has a connective tissue disease, and she's just so much slower in healing because of this connective tissue disease. And she also needed a potent topical steroid. And so I give fluocinamide. Obviously, that is not a prescription that you guys issue. It has to go through me. I have to evaluate the merit. I'm sorry?
That's what Dr. A prescribed for my chin.
Right. What she prescribed also for your chin when you had this kind of reaction, just didn't want to budge. And so these are options afterwards. I'm not sure if they can all be prevented by putting on a steroid directly at the time of procedure, because there are other components that play a role, such as the wound healing ability.
It's like throwing an antibiotic at everything. That doesn't...
Right. And so, I think, again, I'm open to discussion on that. If you guys feel that you would prefer to do topical steroid to everybody after their Infini, but I don't know that
I don't
it's
think
necessary.
it's necessary
It's
for
definitely
some.
necessary to suppress that hyperpigmentation, and that's why we're using it.
So
Right, and-
then we should, sorry, I don't mean to cut you
Okay.
off. Should we also use it for some on the 1540? Because I've only been using it for the Infini.
And so I think for our boy that we always need to stretch the envelope a little bit. Like when we're using the 1540 on skin type 5, which is not so great, we have to think about that hyperpigmentation, and it's supposed to be transient. And I reviewed the literature about that also, and I can't find any permanent hyperpigmentation after 1540. But maybe we should just be using we should maybe try to avoid as much as possible any XF in that person. Although some of those scars, they need some XF for the surface, right? And just use a little bit of the triamcinolone on top of the skin after the procedure, and then hope for the best. But didn't we do that in him? You sure?
We didn't do the catalog.
Okay, all right.
I
So
can double check, but I don't remember. So.
I feel like we did, but maybe not. I thought I was nervous enough to say we should be using that so that he's not hyperpigmenting terribly, but I'm not sure. Maybe I didn't say it. Maybe it was just thinking it.
You used Kenalog on somebody back there. With the 1540, I think you did.
It might be him then. I
I
can
think
double
it
check
was
because I
him.
don't.
Because
I've
I
always
remember
only
you discussing it.
with
Okay.
that or the Infinity. I know for sure.
But
it
nonetheless,
was.
he's still hyperpigmented, but he should also completely move out of his hyperpigmentation. It is it is supposed to be transient. Now, again, if you're treating somebody with the darkest of all black, that super brown color. I remember this patient who has the hypertrophic scars in Center City on her nose. Be careful. Just yesterday I saw somebody back in whom we did a test spot. She's also black. She's technically probably a bit more of a 5 rather than a 6. But she had no transient hyperpigmentation whatsoever. It just didn't occur for her. And so she has hypertrophic scarring on her nose. We also have on our website, so most of you guys may have even seen her either on the website or in the office. She has atrophic scars on the cheeks, and now we're going to continue with some 1540 for her. So I have really no particular reservations, except that you understand how you need to counsel your patients when and what to expect. Because, you may say you can hyperpigment, and the patient hears nothing. Absolutely nothing. Now, I have somebody who came recently. He had photodynamic therapy and wanted the extra delivery route and had the 1540 beforehand. So we opened the skin up so that the aminolevulinic acid can better penetrate into the skin. Now, I want to say 15 portal communications with this guy back and forth. And I also mentioned the 1540 is going to give you some hyperpigmentation. Okay, I have it all documented, right? Mm-hmm. He calls a week later and says, I didn't realize that you actually meant it. Right? No, in his mind, those things he was a skin type 4, and he didn't think it belonged to him. He didn't think he would be the person in whom this really pertains, because he saw lots of pictures of great results on acne after photodynamic therapy. So he was so focused on the end goal that he never questions what pictures he looked at, and there was not a single person with a skin type 5 on there. Just saying. And photodynamic therapy itself gives you transient hyperpigmentation. So now you pair that with the 1540, it's dark, right? Darker than one would expect. Okay, I'm just saying all of these things. Okay, good. So I think we did cover texture today. Next week we're going to go into wrinkles, hopefully skin tightening, and then anything that's deeper. Deeper means muscle and fat underneath. Okay?
Okay.
Good.
Good.